That's not a good statement. How do you check intelligence at the bedside? So don't use that word. See.
So, yes, a dysarthric speech is preferably uses his right hand. His memory, again, could not be tested.
After that, how would you say intelligence is normal without those tests, right? Okay.
So, cranial nerve examination, first nerve could not be assessed. For the second nerve, visual acuity could not be assessed, but was able to see persons. Field of vision could not be tested, and color vision could not be tested. Pupils equally reacting to light. Accommodation reflex present. Fundus.
Right. Because the moment you commit pigment-rich changes, your differential diagnosis gets narrowed down.
So, third, fourth, and sixth cranial nerves, extraocular movements.
So, all the cranial nerves are normal. Or is there any, except fundal changes? So, you can save time, go further. See, I already got spastic quadriparesis. So, I should make a mention about pseudobulbar futures, all those things. Right.
So, spinomotor examination, bulk of the muscle. Mid-arm, it is both right and left side 16 centimeters. Mid-forearm is 11.
If there is no asymmetry, don't spend time on measurements.
So I'm doubtful about there is a wasting of the muscles of the hand. So tone appears increased in both.
Appears is not a word. When you are presenting, you have to be dogmatic. Okay? Right.
Tone is increased in both.
And at your postgraduate level, I will not accept the word tone increase. It will be a little more specific, spasticity or rigidity. Because now you need physical science for anatomical localization. You still cannot keep on saying increase. Why do you say it's spasticity?
So it is velocity dependent. It is velocity dependent.
Okay. What did you find physical science wise? It's dependent on velocity. What else? What's clasp knife? What is lead pipe?
So lead
the
pipe.
resistance offered is not uniform. It gives way. It is velocity dependent. And there are other pyramidal signs which helps me to say this is spasticity. Whereas rigidity is uniform. This I think, unless Professor Chitraman gets approved, I won't go.
Yes, sir.
You're happy? Right, yes. Proceed.
So power.
Right. If you have a shortage of time, you say what is salient. Both proximal and distal are equal. That's what you want to say. Right. Next. The next question, you get the answer. You should tell me the muscles which cannot be classified on MRC grading. Muscles of respiration, axial muscles, intrinsic muscles of the hand, in which you cannot use MRC grading. These are standard questions, right?
So reflexes, superficial reflexes, corneal, conjunctival.
All preserved, plantar is extensive. Try to change the speed of presentation depending upon the pressure, right? That is, you should be able to highlight the positive findings, right?
So deep tendon reflexes, all reflexes are brisk, sir, except for ankle, which are just present.
Right. What is the significance of a word saying knee is brisk, ankle is present?
So whether
You are using two different names. Why?
So according to the grading of the reflexes, according to the grading of these reflexes, ankle reflex is just present, whereas the other reflexes are brisk.
So you think the ankle reflex is definitely not up to your expectations as a nature.
Yes.
Why? What does it click on your mind?
So whether there is any peripheral nerve involvement.
Maybe. All right. That's one you want to say differentially. Right.
So clonus absent. Gait could not be tested.
See, out of the 20 points, 17 points are could not be tested, could not be assessed. So bring the positive findings higher up. And an MD exam, I don't think Professor Srinivas will object to your orderly way of presentation. That is when you elicit. But you should say the positive physical signs and bring down a negative findings a little lower so that it does not appear monotonous. Otherwise, there are 17 negative points and 3 positive points. The 3 positive points gets diluted in your negative history. You should be able to organize it, right?
Sensory system was able to perceive pain, touch and hot sensations. Joint position, vibration could not be tested. Extrapyramidal systems, no involuntary movements. Cerebellar system could not be assessed, but there is no obvious nystagmus.
Right. What are the points on examination which will give you a clue for sensory abnormalities? Trophic changes, trophic ulcers, cool, bluish peripheral extremities, nail changes, and history of not crying when injections are given. So use those things in a very young child to look for sensory disturbance. The standard question, beyond what age you can confidently test the vibration? Usually textbooks say around 7 years.
So autonomic,
Right, rest of it are all normal.
so spine,
Right.
there is
Do
a,
you think I would have preferred to bring the primitive reflex much higher and not at the end, no, even below meningeal signs? Always remember there are another 10 minutes, 5 or 10. Other set of, reflexes, I will never forget superficial, deep, visceral, primitive, so that you don't miss primitive reflex. The spinal motor system, I will not forget to mention about power, tone, nutrition, coordination, involuntary movement. So 5 headings so that I don't miss any physical signs. Right. Continue what Professor Chitrambaram said in about diurnal variation. Diurnal variation in lower motor neuron disease is myasthenia gravis or myotonias. Diurnal variation in upper motor neuron disease is dopa responsive dystonia. When you ask a question, if you say this way, then we know you are confident. Right, rest of it keep going. Right, now discuss the case.
so 9-year-old boy with initial,
No, don't repeat. We all have heard it. Now discuss the case. See, I'm not going to ask you questions, is this neurodegenerative? I'll just keep quiet and listen how you handle the case. Whether you are able to think, because by this time I know that you have got the diagnosis. Are you able to think beyond the diagnosis? Are you able to come to a conclusion, this is the disease, by your argument? Points for, points against. So I won't talk now. Next 3 minutes, whatever you answer, I'll take final marking.
so most
BP is
probable,
quite high now, right?
so most probable diagnosis of neurodegenerative disease.
Don't go this way. So the child has got a progressive regression of milestones. Since there is no clue to recognizable metabolic disease like visceromegaly, dysmorphic features, or KF ring, I am not able to fix it yet, known inborn error of metabolism. Since the child has remained normal for about 3 years, I think the earlier history of development delay seems to be not consistent with this. So this child has got a neurodegenerative disease starting at 5th year of life. That's first you make it. For example, the examiner does not accept that it's 5th year, it's right from beginning. You should argue to say why you thought the onset is around 5th year. For example, if you commit the onset is a newborn and then give me a different diagnosis in which the disease starts at 5th year, I will not accept your argument. So you say it's a progressive deterioration with the age of onset at 5th year. There is no surgical causes like rise intracranial tension. There is no recognizable neurometabolic disorder I could make out clinically. For example, extrapyramidal disorder with increased head size, you will think of a glutaric aciduria. So spasticity, what he wanted was arginase deficiency, which could give you like a spastic paraplegia. Give 2 or 3 such things. Metabolic disease presenting as spastic paraplegia, metabolic disease presenting as extrapyramidal disorders, alpha-beta glutaric aciduria, Wilson's disease. These are not fancies from the textbook. These are conditions which we have seen. Right? Then the next step you say, so this is a primary neurodegenerative disease involving the central nervous system only. There is no other systematic disease. Second, you say in the central nervous system, he gave you a clue. Are you going to call it predominantly gray, predominantly white? Your argument saying it's predominantly white, I don't think I will accept. The child presenting with the deterioration and seizures may indicate a gray matter, but the predominant second set of deterioration now versus spastic paraparesis earlier, hence I think it is a predominant white, I won't say white, predominant white matter disease. That's our second category. The third category will say this predominant white matter disease has the following features. What? To make a specific diagnosis. So you say it's a white matter disease starting at 5th year of life. Okay? Right. Now, the next word you say will know whether you have got a reasonable. What do you think? Closest diagnosis.
So with the normal head, white matter with only CNS involvement with the normal head size.
So what are the possibilities?
So one thing is adrenoleukodystrophy.
I'm sorry, I'm blunt. I'll fail you straight away. What is the point in your history or examination which gave you a clue to adrenoleukodystrophy?
So
Then why did you
only
use the
thing-
word?
Head circumference is normal.
Why did you use the word? You are given all the physical signs against adrenoleukodystrophy and you are calling it as adrenoleukodystrophy. So you would have probably, if I were your candidate, I would not use the word adrenoleukodystrophy until the examiner asks what else. Then I would have said, one of the possibilities is adrenoleukodystrophy. However, there is no hyperpigmentation of the skin, and the pigmentary changes I have not documented. Hence, I would like to think of adrenoleukodystrophy only, not clinically, but at the end of investigations. The next area where I would probably build up, if you are sure on pigmentary degeneration, then I would to say neurodegenerative diseases with pigmentary degeneration would include mitochondrial diseases, I'm not giving you the entire medical, a few things for us to convince the examiner that I know some amount of neurochemistry. Neurosteroid lipofuscinosis, mitochondrial diseases, adrenoleukodystrophy, mucopolysaccharidosis. See, all as pediatrician, remember you have seen all those conditions in the last 2-3 years. You would have seen mucopolysaccharidosis in any number. You would have seen neuronal steroid lipofuscinosis. You would have seen adrenoleukodystrophy occasionally, and rarely SSP. But the presentation here is not like SSP. So you should bring all those points and wait for the examiner to ask what else. That is, the examiner wants to know whether you have thought of adrenoleukodystrophy. I give an impression that in the absence of hyperpigmentation of the skin, clinically, though the age of onset and the tempo fits in, I am not able to think of adrenoleukodystrophy. You should say points against adrenoleukodystrophy and a clinical side. The moment you say your first, right from beginning, your first diagnosis has been leukodystrophy, but you have been careful to avoid the word adrenoleukodystrophy at the history level. But now the point which probably misled you was treated a CMC with some oil. I would have probably used the word some drugs. I would not have used the word oil. Show the examiner that I got a bias. So I would say it's a neurodegenerative disease starting at the age of 5th year of life, only central nervous system involved. As he mentioned, both central nervous system and peripheral nervous system involved. Hence, I think of the differential diagnosis. Don't come and straight away land on adrenoleukodystrophy. I would request comments by Professor Chitras and Professor Srinivasan, a potential examiner. Why I want it is not for that. How does a pediatrician look at you? How much of these information he wants? How do you progress? That way, his comments will be very useful for us from the exam point of view. ಅವ್ರಿಗೆ ಮೈಕ್ ಕೊಡ್ತಾರೆ.
Yeah, I think my view as a general pediatrician is the same as yours. So we must not go by history, especially I also wanted to know because of the CMC, Lorenzo oil or something, he has made up his mind to be a mitochondrial dystrophy, this thing, no? So you must not metachromatic leukodystrophy, you should think of low in the list as he has mentioned. So you have to say white matter degenerative disorder and tell what are the points in which you will think of differential diagnosis, and then mention metachromatic leukodystrophy and then talk about it. Okay, there are so many points as Dr. Kumaresan mentioned. It's a difficult case, I can agree with that. Okay, because there are so many differential features which are not fitting with any specific leukodystrophy. But you can come to a conclusion it's a leukodystrophy which is having onset at a later onset, not infantile type.
Now give the investigation findings in 1 minute for Professor Chitras.
What were the investigations done? How was the case worked up?
So in this case,
If an exam student, I'll say I do not know anything about investigations. Right? Anyhow, since you know, you have brought the case sheet, give it.
so MRI brain was done, sir. Apart from routine investigations, MRI brain was done, which shows features of white matter disease. They are given most probably adrenoleukodystrophy to rule out other white matter disease also.
Why did they say adrenoleukodystrophy?
So specific.
Why do you say adrenoleukodystrophy on the
So
MRI?
based on the areas of the involvement.
Keep talking, don't give one word answer.
So based on the areas of the involvement,
More characteristically in the
splenium of the.
posterior region, paretoxis, with contrast and aspect. Supposed to be very characteristic of adrenoleukodystrophy.
They have done the levels of very long chain fatty acids, C26 and phytanic acid, pristanic acid, and the levels of long chain fatty acids were elevated. Sir.
Very high. Other blood investigations were done. Only very long chain fatty acids straight
And
away.
phytanic acid, pristanic
If
acid.
you think about a MLD, what investigation will you do?
So aryl sulfatase levels.
Aryl sulfatase A or B?
Yes.
Aryl sulfatase B is deficient in which disease? aryl sulfatase A in metachromatic MLD, aryl sulfatase B is deficient. Which disease? Any of you can say? It is in one MPS. One mucopolysaccharides, you have aryl sulfatase B deficiency. What is that? Any of you know? The mucopolysaccharidosis, you know the list of diseases. In which MPS you have aryl sulfatase B deficiency? Pardon? No. Marquis he is telling. Yes. Always remember, MLD is metachromatic leukodystrophy, aryl sulfatase A, and another MLD MPS is Moratti-Lamy disease. So Moratti-Lamy you have, there is another MLD where you have aryl sulfatase B, right? So this is small mnemonics to remember the aryl sulfatase A or B. And urine you can look for metachromatic granules that you can do in a urine examination, right? And always remember, any undiagnosed spasticity, you can ask for a few investigations, A, B, C, D, E, like that. A for ammonia and amino acids, B for biotinidase, C for cholesterol, and D is missing, that is total homocysteine, E for vitamin E, F for folate, and fatty acid, that is very long chain fatty acid. Remember this. If you have a undiagnosed spasticity in a child, the blood investigation that you can ask for is A, B, C, D, E, F, like that. A for amino acid and ammonia, B for biotinidase, C for cholesterol, D is T, that is total homocysteine, E for vitamin E, F for folate and fatty acid, that is very long chain fatty acid. So probably when you do all that, you catch the very long chain fatty acid also. But very long chain fatty acid is not done everywhere. The blood, I think blood has to be sent to UK to get it done. It is not done here, right? So anything else?
Can I ask one question, sir? The ankle jerks were brisk or diminished?
So nerve conduction also showed a demyelination with the secondary axonal.
I wanted to know whether the nerve conduction study, you haven't mentioned it. They have done it there. Okay.
I think we have overshot that time. Leave it till. Well, thank you. Good presentation.
Thank you, Dr. Jagadish. I now request Dr. G. Kumaresan to hand over the gift of appreciation to Dr. Jagadish. I now request Dr. Chitrambalam to please hand over the memento to Dr. Kumaresan. I now request Dr. Kumaresan to please hand over the memento to Dr. Chitrambalam. Thank you. The next case is CVS, rheumatic heart disease. I request Dr. Shruti to please come on stage. The moderators are Dr. Jnana Sambandam and Dr. Jabraj. Please come on stage. Thank you. I request Dr. Srinivas to join us on stage, please.
Good morning, one and all. Here is a girl, 11-year-old, by name Miss Neha, coming from Panbudi, third born of non-consanguineous marriage. Informant's mother, who is reliable, has been brought with complaints of breathlessness for the past 1 year, swelling of legs, abdominal distension for past 2 weeks, associated with chest pain and palpitations, and left knee joint pain for past 2 days. History of presenting illness. Apparently normal girl till past 1 year. She developed breathlessness, which was present initially only on severe exertion, such as running or playing at school, as described by her, that is class 1, and used to get relieved by rest. It has gradually progressed over a span of 1 year to breathlessness at rest uh, for the past 2 weeks, that is class 4. She also gives history of orthopnea. It is associated with swelling of both legs noticed for the past 2 weeks, increased as the day progressed, and in a span of 1 day, she developed facial puffiness and abdominal distension, which was progressive. There is also history of chest pain for the past 2 weeks, which was described in the left precordium, brought on mild to moderate exertion, pricking type, non-radiating, not increased on cough or deep inspiration, no relation to the food intake. There's also history of palpitations for the past 2 weeks, which was felt on exertion. There's history of fever 2 weeks back for 1 week, which was moderate grade, intermittent, not associated with chills and rigors, relieved by medications, but was associated with pain abdomen, localized in the right upper abdomen, vague, intermittent, not related to food intake. This history of joint pain for the past 2 days involving the left knee joint, which was aggravated on walking, causing her to limp and relieved by taking rest. It is not associated with swelling or redness or local rise of temperature. Other joints are not involved. No associated morning stiffness. The history of easy fatigability and weight loss and loss of appetite is also present for the past 1 year. There is no history of skin rash or involuntary movements or skin nodules, no history of reduced urine output, no history of cough, cold, burning, micturition, myalgia or joint pain, no history of sore throat in the recent past, no history of syncope or bluish discoloration of skin, lips or recurrent respiratory tract infection, no history of seizures or hematuria or other history suggestive of infective endocarditis. Past history, there is no history of joint.
This particular, you have mentioned child had problem for 1 year, breathlessness, which is increasing in severity to the present status class 4. And then the second paragraph you have mentioned, associated swelling of both legs noticed for the past 2 weeks. And then subsequently I mentioned the third paragraph, chest pain in the 2 weeks, localized in the left precordium. Which should come first? The chest pain and then subsequently the decompensation should come, or see, I mentioned both are 2 weeks duration. So which will you give importance? Because suddenly child is deteriorated. So from the class 4 status, developed edema, feet, etc. So naturally child has gone into a decompensated state. So something has happened at the same time, okay, which is a precipitating event I feel. That is pain in the chest pain, which was not there earlier, has become as an important symptom. That would have precipitated this particular decompensated state in a compensated heart disease. So what is the cause of the chest pain? I want you to tell the differential diagnosis of chest pain at this state.
Chest pain can be due to carditis. In this case, as there is a history of progressive exertional dyspnea, I would like to think in terms of cardiac cause of chest pain. Can be a pericarditis or a myocardial involvement causing chest pain, or left ventricular dysfunction due to a regurgitant lesion, valvulitis. Aortic, mitral.
So you mentioned carditis, myocarditis had occurred at that time. That is one possibility. The second possibility would be a valvular component. Okay, so probably this child had another valve involvement at that time. So what could be the valve involvement if it is so? I'm not saying it is valve involvement, okay, but a child who has been in the early stage of breathlessness has suddenly gone into class 4 and gradual deterioration is occurring. So if valve is involved, chest pain is associated with which valve involvement? You said no syncope.
Aortic valve involvement.
Aortic valve involvement. So is aortic regurgitation or aortic stenosis?
Aortic stenosis associated with chest pain and
You said it's your
syncope.
palpitation
There's
subsequently.
no
then.
syncope, so I would like to think in terms of regurgitant lesion.
Okay, so aortic stenosis takes longer time to develop. So aortic regurgitation can occur suddenly and create change in the scenario. in the presenting scenario. Okay. Yes. Next slide.
The character is also, it doesn't increase as your slide shows on exertion. Does it have any clue? Chest pain on exertion, pricking, both are controversial. Pricking will favor pericarditis. The pain which increases with your exertion favors low cardiac output causing angina-like symptoms. So both are contradictory.
Because the pricking type pericarditis is more likely than aortic regurgitation causing, because there will be anginal type of pain.
Yeah, you carry on, carry on. Because chest pain, the things are very contradictory with your activity and with your inspiration, deep things are very contradictory. Okay, carry on.
Past history, there is no history of joint pain, swelling or skin rash, nodules or involuntary movements in the past. No history of previous hospital admissions, not on any drug. Treatment history, for the above complaint, she was admitted at local GH, given IV and oral drugs, done an X-ray, said to have heart disease, and was referred to higher center for further management. Antenatal, natal and postnatal history, she was born out of a full-term normal delivery, birth weight is 2.75 kg, cried at birth, it is uneventful. Developmental history, has attained age-appropriate milestones, at present studying in 7th standard, good at studies, used to get first rank, but at present she is not attending school for the past 3 weeks due to the present illness, and in the last 1 year, she used to not participate in physical activities because of her ailments. Immunization history, immunized according to the national immunization schedule, optional vaccines not given. Nutritional history, she takes 1350 kilocalorie against 2000 kilocalorie, the gap of 650, that is 32.5% deficit, and protein of 24 against 36, the gap of 12 and 33% deficit. Family history, she is third born of non-consanguineous marriage, has 2 elder brothers, no history of similar complaints in the family members. Occupation and socio-economic history. Father is an agriculturist by occupation, has studied up to 5th standard, is the only earning person. Mother is a housewife, illiterate. She belongs to a nuclear family. Per capita income is 4,000 per month. There are 5 members in the family. They live in a thatched house with cement flooring, 2 rooms, 1 window per room, not cross-ventilated. The water they drink is from the corporation tank. They drink unboiled water and practice open-air defecation. They belong to a lower middle socioeconomic strata. As per the modified Kupus-Comi scale, the score comes to 12. Summarizing the history, this is an 11-year-old, apparently normal girl, belonging to a lower middle socioeconomic status, presenting with progressive exertional dyspnea, which has increased for the past 2 weeks with chest pain, palpitation, anasarca, fever for the past 2 weeks, and monoarthralgia for 2 days. I would like to think in terms of an acquired heart disease, probably a rheumatic with symptoms of congestive cardiac failure, and also I would like to rule out recurrence. And second possibility can be a dilated cardiomyopathy.
So probably you should say acquired heart disease with rheumatic heart disease with recurrent. No, that first point is not so clear. So do you think the
Probably a
whole
recurrence.
1 year episode is rheumatic fever?
Sir?
Do you think this whole 1 year episode, the 1 year course, is rheumatic fever?
It can be because of established heart disease causing cardiac failure.
So maybe you should say acquired heart disease, rheumatic heart disease with recurrence of rheumatic fever. Now that would be better than, this is not so clear, rheumatic origin with congestive cardiac failure due to rule out recurrence. Now, do you have features suggestive of recurrence now?
involvement of presence of fever and involvement of joint pain and worsening of the symptoms.
Yeah, definitely there is recurrence of rheumatic fever now. Now, what do you think, doctor?
Yeah. Any other DDs like congenital heart disease presenting this late presentation of congenital heart disease?
Large PD.
Those will be symptomatic even previously. Any bicuspid aortic valve
aortic valve.
that's going to degenerate causing ASER. Any coarctation that can present at the second decade also.
In addition, what will be the diagnosis? As mentioned, sarcoid heart disease, rheumatic, most probably rheumatic in origin because there is one joint involved at this time. And then you yourself mentioned when I asked you what is the cause of chest pain, there is likely to be myocarditis. That means you have to
Active
include acute
carditis.
carditis. Okay, that is also part of the recurrence phenomenon. Just like you say nephrotic syndrome in relapse. Okay, similarly you have to mention if there is active carditis, then the treatment is different. So you have to bring in your diagnosis from the history. Of course, we haven't gone. So you have to mention probably child is in active carditis necessitating treatment. That is why sudden deterioration in the state, cardiac status from grade 4 dyspnea child has gone into bed rest with pedal edema. So one of the important statement NADAS mentions is there is in a child there is a symptom of failure in rheumatic heart disease, always consider carditis unless proved otherwise. Okay, so it is important even in tropical country. Now most of the children are treated with antibiotics. The moment the child has fever and cough, immediately antibiotic is given. In spite of it, child goes into cardiac failure, means that you have to think of active carditis again.
Moving on to the examination. General physical examination. Child is sitting on the couch, oriented, conscious, undernourished, in respiratory distress. Severe palmar pallor is present. No clubbing or icterus or cyanosis or lymphadenopathy or pedal edema. Vital signs: resting pulse rate was 100 per minute. Large volume, regular in rhythm. Character and condition of the vessel wall normal. No radial or radiofemoral delay. All peripheral pulses were well filled. Sleeping pulse rate was recorded in the ward taken was 90 per minute. Respiratory rate was 30 per minute. Thoracic type. Accessory muscles of respiration was in use. BP was recorded in all 4 limbs. In the supine position, it was 90 by 16 right upper limb. JVP was normal. Temperature was 98.6 degree Fahrenheit. Anthropometry, weight was 24 kg against 36 kg, which comes to around 66.6%. Height 138 against 143, 96.5%. BMI was 12.6, severe thinness, less than 3 standard deviation. Head circumference is normal, arm 7 was also normal.
Is there a significant difference between the BP of upper limbs, left and right? Diastole. You recheck diastole. Usually the diastole will be equal in all 4 limbs. Even in coarctation, only the systole is affected, not the diastole.
Moreover, you said large volume pulse, but the pulse pressure difference is only 30 here, which is still unlikely. Either the BP has not been taken properly or the pulse has not been recorded.
So go back to the previous slide about pulse, because we are thinking of rheumatic heart disease and rheumatic fever recurrence. What else do you expect?
Tachycardia.
Tachycardia, okay.
Muffling. Can be arrhythmia can be there, an irregular rhythm.
Yeah. And also collapsing pulse, those things probably we should look for.
Collapse.
Acute deterioration should, probably there was a regurgitant lesion which has happened now, or a myocarditis. So 2 regurgitations, either aortic or mitral. So aortic, if there was severe aortic regurgitation, you could you also mentioned large volume, so possibly you should look for collapsing pulse.
Another important point is severe palm or pallor. Child is having anemia as such. And then in spite of it,
Heart rate is low.
yeah, heart rate is
You have a
almost near
cardiac-
normal, and large volume pulse you have mentioned, but the pulse pressure difference is very less.
So you recheck the pulse rate.
And
In
when
spite
you're
of it, if this thing, no anemia, you find the systolic blood pressure is only 100 in a 13-year-old child or about 10 years of age, and then you find the volume, pulse volume is low, we have to think of a aortic stenosis, an association, okay, because there is a systolic decapitation. So if there is a severe pallor, if it is true, okay, anemia less than 7 grams, then pulse should be large volume, and the BP also will show a hyperkinetic this thing. So that will be loss of pulse difference, no, pulse pressure difference. A little inconsistency is there in the findings. Okay, yes.
what did you fail to mention here, which are very important in this child? We are thinking of acute rheumatic fever now. So you should have other signs of rheumatic fever.
Have included in the next slides.
Oh, yeah. Okay.
What I am trying to say is that you have to be extremely careful when you are recording the pulse. Okay, especially in heart case, associated anemia can change the findings drastically. Even murmurs can appear, which can misinterpret it.
Anything you can think when the pulse rate is low but irregular?
Heart flow.
Hmm? It could be atrial fibrillation in an older child, not in this age group, wherein your heart rate will be around 120. Pulse rate will be irregular but lower. Pulse deficit can be there. Okay.
Tanner staging is a stage 2, head to foot examination, no dysmorphic features. Dental caries are present in bilateral lower first molar teeth. Oral cavity is normal, tonsils not enlarged, pharynx not congested, no cervical lymphadenopathy. Left knee joint is tender, no swelling or redness or increase in temperature. Restriction of movements is present, limbs on walking, no other joints involved. No skin rash or subcutaneous nodules or involuntary movements. No signs of infective endocarditis. No peripheral signs of AR, no morphinoid features.
Where do you look for subcutaneous nodules?
Over the extensor aspect of the bony prominence, wrist, elbow, over the
Like
scalp.
start from the head.
Occiput,
Yeah.
spinous processes, then olecranon process over the wrist, Achilles tendon,
Malleoli.
malleus.
How long does it last? If it's present. Especially in our clinical life, we should see it every day. It might be, it could be very transient, present for 1 or 2 days and disappear. Are they tender?
Non-tender.
Okay. But once in a while it could be tender, but generally non-tender.
Can you describe a subcutaneous nodule? Typical size, mobility.
0.2 to 2 centimeter,
Point?
2 to 2 centimeter,
0.2. 0.2 is too small.
0.5 to 2
Ah,
centimeter.
okay.
Mobile, non-tender. Seen
Have
in
you
the-
seen any time?
No, sir.
Not at all.
Is it mobile, immobile, fixed to the deeper structures?
Subcutaneous, so it is mobile.
Is it mobile? No, is it fixed to the deeper fascia?
Don't know, sir.
Okay.
Forgotten rheumatic or disease.
Systemic examination, cardiovascular system. On inspection, shape of the chest appears to be normal. Trachea appears to be in the midline. Apical impulse is seen in left sixth intercostal space, 0.5 centimeter lateral to the mid-clavicular line, hyperdynamic in nature.
Yeah, 1 minute, I wanted to make this comment. For example, when you are seeing the joint tenderness and limitation of movement, it's important to see for effusion also. I still remember when Dr. Ramesh will be coming soon as a pediatric neurologist. He was my DCA student in JIPMER, and CMC Vellore Dr. Malati Jadhav was examiner, and he couldn't elicit the patellar tap properly, and then that was the main reason he was failed. Okay, and then he didn't appear again, and he got this thing, he wanted to go to England, though he got MD seat in JIPMER after entrance exam. But he asked me whether to go there or not. I said, if you don't waste anybody's seat, if you want to go, you go. And now he is a pediatric neurologist, and he is coming here recently. He will be here in the neurology conference, which is going to take place. So, an important point, if you find arthralgia and pain and limitation movement, it's important that you examine the joints very carefully, and if you miss a fusion, depends upon the examiner's attitude. Even a single finding can be a reason for regret later on. Yes. Now you can proceed.
Apical impulse is seen in left sixth intercostal space, 0.5 centimeter lateral to the midclavicular line, hyperdynamic in nature. Parasternal pulsations are seen, epigastric pulsations are seen, no dilated veins, scars or sinuses.
It will be nice if you also give the interpretation. Once you see a positive finding, so what does it indicate? So that it will become much more easier for you for discussions. With parasternal and epigastric pulsations. Okay. Yes.
Cardiomegaly is there, both shifted outwards and downwards.
Okay.
Parasternal pulsations can be due to right ventricular hypertrophy, volume overload. An epigastric pulsation can also be due to RVH.
Why do you use appears to be
On inspections.
inspection?
On palpation, position
Just
of the
now he mentioned, the previous discussion, never mention appears. Okay, Dr. Kumaresan very rightly mentioned, never be doubtful in your findings.
You be
If you-
categoric.
shape is
No, shape you are going to only inspect. You're not going to palpate. No, shape is normal.
there's no. What I meant to say was there is no precordial bulge.
No, basically you just avoid the term appears.
Okay.
Be more sure. Everything appears only.
On palpation, position of the apex speed confirmed in the left sixth intercostal space, 0.5 centimeter lateral to the midclavicular line, hyperdynamic nature and is associated with thrill. A parasternal heave of grade 2/3 is present. No other palpable sounds or rub.
Yeah, again, A has come in front. Somebody mentioned that he was mentioning in consanguineous. Okay, yes. Okay, next.
On percussion, left border
How
of
do
the
you
heart.
grade this parasternal heave?
Grade 1 is parasternal pulsations are seen but not felt. Grade 2 is felt but obliterable. Grade 3 is felt and non-obliterable. On percussion, left border of the heart corresponds to the apex beat, right border of the heart beneath the right border of the sternum.
Just a minute. Actually, I was taught, and also I try to teach whenever we take a class, at the end of percussion, you should have sort of come to a diagnosis. And auscultation is only to kind of confirm and see whether you're missing anything. If you base everything on auscultation, it's very difficult. You will hear a lot of sounds, especially in the exam, you will misfire. So at the end of percussion, what do you think, kind of broad, what do you think is the problem with this child?
Cardiomegaly is there.
Cardiomegaly, yes.
It's a biventricular, both left ventricle as well as right ventricle is involved.
Parasternal heave means
Features
what?
of right ventricular involvement is presence of parasternal heave
Okay.
and epigastric pulsations.
What else could give a right parasternal heave?
And cardiac enlargement both outwards and downwards due to left
So this is
ventricular
kind of a left ventricular kind of apex, right? And parasternal heave or lift present. What all could give this parasternal heave or lift? Right ventricular hypertrophy is one. What else could give?
tricuspid regurgitation.
Tricuspid. No, that causes right
Left
ventricular dilatation.
atrial enlargement.
Pardon?
Left atrial enlargement.
Left atrial enlargement. If it's pulsating,
Aneurysm.
it could be a severe mitral regurgitation. So then what else could give a left parasternal lift? we should think of three things. One is right ventricular hypertrophy or right ventricular obstructive lesion. Second is left atrial enlargement like severe mitral regurgitation. Third would be if there is an aneurysm or something behind which is causing a pulsatory swell. Do you think there is pulmonary hypertension?
Right ventricular hypertrophy is there.
Okay.
How do you differentiate a parasternal